Hi, everybody. I'm Don Dolcinos, the founder and organizer of TransTech Boulder, and welcome you to this, our second in a series of webinars, events. All the events have been webinars so far, because that's the time we're in. But appreciate your interest, especially in this topic, which is one that's near and dear to me. So I'm going to take a couple of minutes and introduce TransTech. I think, Pierre, in terms of the audience here, somewhere around 2/3 of the audience comes from the TransTech community that exists. So it's either local folks or national or even international. And in fact, we had folks from, I was counting earlier, England, France, Italy, Switzerland, Egypt, Israel, and a couple more countries. So it's truly a global organization. So it'll be interesting. And all of them have, I think, some degree of understanding of brain-computer interface technology, and that's kind of why they're here. Maybe not at the full research level or the medical level, but I think the way we've set up your conversation here, you're aiming at the right level. So welcome, everyone. And for those of you who, okay, now we will do this the hard way. Bear with me. This is advice to myself. Take a breath. Everyone who's coming from one webinar to the next webinar, just take a breath. Be here with us. We've got a good hour of fun ahead of us. I'll do a brief introduction, maybe less than 5 minutes, and then turn it over to Pierre, who is our featured speaker. And towards the end, if folks have time to stick around, we'll talk a little bit about the chapter, the TransTech chapter in Boulder and Colorado generally, and see who is interested in getting more involved. So with that, here is the mission of the TransTech transformative technology community globally. There's the mission statement: to permanently move 1 billion people into a state of well-being and flourishing by 2030. You know, very modest goal, but a lot of people are getting after it. And who we are is a community of entrepreneurs, innovators, investors, researchers, all working on building technology that's specific to these ends, to improving mental wellness, emotional well-being, and human flourishing, kind of broadly defined. So there's a lot of technologies that go into that. The third bullet kind of talks about some of them: network sensors, neurofeedback, robotics, and more. We'll talk mostly today about EEG, but not only about EEG technology here, but the ambit of the organization is pretty broad. And just briefly, the 3 things that TransTech does: puts on an annual conference, which has been going on for about 4 years now, and is growing 30–40% in attendance each year. So it's clearly in a space where people are interested. The organization also runs an accelerator program, a startup accelerator called the TransTech Academy. That happens every year in September, October, 6-week program. We can talk more about that later. And then mostly it is a broad-based community. And so we are TransTech Boulder here, but there are more than 50 chapters and active chapters of the organization. So there's a lot going on. We share back and forth, these attending each other's seminars as well as doing our own thing locally. So welcome to all of you, especially who are my fellow chapter leaders in different parts of the world. And this is the one where I'll stop, and I'll come back to these slides later. But I'm looking for more help on organizing events and doing more kinds of planning. I think, you know, as an information sharing and business networking function, that's pretty easy to do, and I've been doing that myself. But we want to do more. And I think I mentioned the accelerator earlier. I think there are several startups in this community in Colorado who would be very interested in participating in the TransTech Academy Accelerator program. It's a great audience of a great staff of mentors, and investors, and folks that know how to grow a business. And so that's available. And then maybe we get together in person in November when the conference is scheduled, at least, to take place in person. And we can maybe do that as a joint effort. So with that, I'm going to move to the next and introduce Pierre Brunschwig, whose face you should be able to see. Pierre is a family medicine specialist in Boulder, Colorado. He's been practicing more than 30 years here. Graduate of the University of Colorado at Denver, and his practice is pretty broad-based, not just the technology we've talked about, but he takes a pretty integrated medical approach and supports a pretty broad view of wellness and healing. But he's going to tell you about that as well as give you the presentation. So Pierre, welcome.
Thank you, Don.
And
I mean, genuinely, thank you. I feel honored to be able to talk to you guys, and I'm looking forward to more interactions on this level. It affords me the opportunity to get out of my office, and that is a very refreshing kind of new perspective for me, you know, because I'm often hip deep in clinical information and taking care of patients. So this is obviously the mission statement for TransTech and is well aligned with my own values and the way I've fashioned my practice. And so today I'm going to orient you a little bit about our practices. I want you to understand the context in which I'm using the technology that I do use inside my practice. And with the idea that you will interact with that and bring in your own perspective out of, and as a non-clinical observer of what I'm doing, and give me some new insights as to how we might use these things outside of clinical practice. And, or if you become interested in it in the clinical setting, that would be another interesting thing we can do on a more professional level. And my interest in integrated medicine goes back before there was such a word. And so even before medical school, I was interested in all kinds of different medicines, if you will, like Chinese medicine and Ayurvedic medicine. But integrated medicine is growing in terms of the number of practitioners, and it's growing because there's an ever-increasing need to address the fragmentation of conventional medicine. And so conventional medicine is a paradigm. Like any paradigm, it's strong in some places, and it has dark or shadowy places where it's not so good. And so integrated medicine basically says, you know, there's a lot of power in terms of being able to understand more than one paradigm. And a paradigmatic thinking allows you to treat more people and more different kinds of conditions. Next slide. And so in specialty care and conventional medicine, everybody has a perspective on their elephant, if you will. Everybody is correct and nobody is complete. And this lends itself to, well, some of the strengths and weaknesses of conventional medicine, right? So in training, we're really encouraged to dive deep into the specialties and into the fine detail of particular systems. But there is not this sense of coming back around and putting all the pieces together. And patients, of course, experience this. Well, physicians also experience this. Next. So when I was younger, way younger, you know, in high school, I was attracted to meditation. I've been meditating since. And I've done extensive travel. I speak another language. And like earlier, I studied Chinese medicine and Ayurvedic medicine. And then as a professional, dove into nutritional medicine and what we referred to in the 90s as holistic medicine. Now we call it integrated medicine. And was active throughout my medical career in terms of supplementing my education with things non-conventional. So even within medical school, we insisted that there be a meditation room within the library we started an elective in biofeedback, and we started an elective in holistic medicine, because while I've got to be honest, I loved my medical education, I knew before I began, it was going to be a very specific sort of education. Next. And so in residency, one of the early technologies in the 90s that I helped introduce as a resident was obstetrical ultrasound. And it added greatly to our ability to monitor pregnant women as they go through their pregnancy. And it was a joy to use a non-invasive technology in such a happy setting, generally speaking. And then in practice later, in private practice, I really wanted to know more about what happened in sleep, you know, because for decades, sleep was really this black box. Nobody was certain why we did it. And how did we know if somebody had a good night's sleep? And so for probably 20 years now, I've been doing what's referred to as overnight oximetry on people to peer in while they're asleep to see what their oxygen and their heart rate variability looked like. And then more recently, in the last 12 years, I've been very excited to have, again, a non-invasive ultrasound. This one is specific for looking at the carotid wall, which we call the INTIMA, and measuring that with the help of a tech, of course, as a way to monitor vascular health. Because while there are many blood tests, some of them are not very specific for inflammation and long-term health of the blood vessels, especially the arteries. And so the carotid ultrasound, the carotid INTIMA thickness was another way for me to non-invasively bring a technology that really was helpful in terms of this common issue with cardiovascular health. And then supplemented my education. Education, you know, wasn't a formal education. Back then you just had to, you learn all these things on your own. With functional medicine testing of all kinds. And functional medicine is an interesting response in medicine to filling a gap that is created, sometimes quite a large gap, from wellness on the one hand and pathology on the other. And so in conventional medicine, we're very pathologically oriented. In other words, when something is actually broke, and then it can show up in a medical text, and yet it didn't have a lot to say about wellness. And as it turns out that many people on the way to their pathological state, say diabetes, they often would have these functional problems. So for instance, in the example of diabetes, they would have some dysregulation of their blood sugar. And this was true in all systems, so immunologically and gastrointestinally and neurologically. So there were all of these functional disorders that usually predate the onset of a pathological, able to find in a textbook disease. And we wanted, me being very preventive oriented, I wanted to know who was developing these functional problems. Plus, this was a group of things that conventional medicine did very poorly with. So they would include things like chronic fatigue and fibromyalgia and irritable bowel syndrome and irritable bladder and brain fog and any host of other things that really didn't have a conventional test. And while they may get a diagnosis, mostly those diagnoses were a way to help specialists get on with people who had real pathology. And then most recently, I've introduced the WAVI EEG scan into my practice because we really needed to get more information about the biology of the brain. Next. And so moving backwards for a moment, we're going to talk about the carotid intima, and we're going to work our way from the neck up into the head. And so the ultrasound that I'm referring to, the carotid intima thickness, tells us about the wall of the artery. And generally speaking, It's a very quick, non-invasive ultrasound. It gives us a very refined sub-millimeter measurement of the middle part of the carotid artery wall, which tells us about its puffiness or its inflammation. And inflammation, we know from research, when it mixes, for instance, with elevated cholesterol, is the most incendiary kind of cardiovascular problem. When you have inflammation and elevated cholesterol, we know that those people are at higher risk for stroke and heart attack and other cardiovascular disease. So knowing what sort of inflammatory state the artery was in was a big help in terms of personalizing people's cardiovascular programs and either reassuring them that there wasn't or helping to address the problem when we saw it. Likewise, we could also see very refined measurements of plaque. And that, of course, is another important thing, because when you measure, for instance, cholesterol in people, that is a risk assessment tool, is what we refer to that in conventional medicine. And which means that people like you with cholesterol like that tend to have these kinds of cardiovascular problems over long periods of time. And so it's really a risk assessment tool. It's not really telling the individual specifically what they're doing with their cholesterol. And with this ultrasound, we could tell them specifically, look, you're making a lot of plaque, even though your cholesterol is not very high, and so we need to redress this. So it helped us to find the outliers in the risk pool, people who underproduce plaque or overproduce plaque, inconsistent with their cholesterol readings. And it helped us to refine and individualize the care, plus it gave us a non-invasive way of monitoring, all of which are the kinds of things that we want in primary care. Next. And so you can see from this diagram, if we move to the left, we see an artery that is with wall that is not puffy, nor has it developed plaque, which you can see as a yellow layer that is moving to the right, becomes more and more thick. And so we can see not only does the wall thicken, but we can see that the plaque can thicken too. And so this gives us basically the pathological progression of atherosclerosis in this diagram. And we see, as we see with everything in biology, we see everything. We see people with wall thickness issues, we see people with plaque issues, we see them together or separately. And the blood tests don't always help us to forecast what we're likely to see in the blood vessel. So having this information really helped us to peel open those two important pieces of the pie in terms of cardiovascular risk. Next. And then here's an image. It's a black and white image. This is one of the clearer ones I can find. There is, in this, what you're seeing is the carotid artery with the intima and media and the adventitia documented here or labeled here. And then as you move to the left, you're looking towards the head of the patient where the artery is going to bifurcate. And so that's why it widens over there. And so I wanted to give you just a 2-by picture of what we're looking for. Next. And of course, while we were doing this for so many years, I was fairly convinced that as I was improving the health of the blood vessel that goes to the brain, I was also helping the brain. And although I didn't have proof of that, or at least I didn't have proof of that until recently. And so we were pretty sure that improving inflammation and decreasing cholesterol and improving cardiovascular situation as documented with the arteries just underneath the brain would be helpful. Next. And we also, paired with that, we have this very frustrating situation with understanding the health and the biology of the brain. And one of the most frustrating places to do research is in Alzheimer's disease. And there's a giant graveyard of medications that have been tried to treat Alzheimer's disease. And to make a long story short, this clinical, or I should say research experience in Alzheimer's taught us in a painful way, that by the time we're seeing cognitive problems in people, by the time people are complaining about their memory, the disease process has been going on for decades. And that we are way too late to the party, and therefore intervening with the medication is too desperate and too late in the normal history of the pathology of Alzheimer's disease. And we really needed tools that identified biological function before cognitive decline. And we're still struggling to get there, although we're making additional progress in terms of Alzheimer's disease. And the same thing was true for me, is why I was very excited to be able to tell patients that their carotid arteries look good and that this was probably reducing their risk of Alzheimer's disease. I couldn't tell them with any certainty that was the case. So we really wanted a reproducible, non-invasive, inexpensive, and treatable measurement that had to do with brain biology. Next. And then here comes the WAVI brain scan. And so it was in its context being able to treat cardiovascular disease and monitoring very closely for years cardiovascular health in the carotid, that it just made sense to me clinically that this was an important next step in being able to address this issue in my clinical practice with how do we tell somebody, besides asking them lots of questions on a questionnaire, right? How do we tell somebody that their brain is working optimally or that it is not working optimally? And so the WAVI brain scan weds an old technology. Well, actually weds two old technologies is really what it does. The EEG's been around forever. As it turns out, I had idiopathic seizures when I was a kid, and back in the 60s, and they didn't have any fancy technology, and they actually used small little pins to puncture my scalp to keep the darn things in place. And then I had to hold perfectly still. So the EEG has been around for a long time. And it turns out that the auditory part of this coupled technology has also been around for a long time. So here you can see a picture of me wearing the EEG headset and a set of headphones as well. And what the WAVI has done in combining this technology is they've taken what we know in terms of auditory processing science, which is lengthy, and they've wedded it with a portable EEG machine. Next. And so the EEG machine can measure two important things. We're going to talk about both of them, but we're going to start with power. And so power, when we're talking about the brain, is measured in voltage. And so the more neurons that are active and the more active they are, the higher the voltage can be monitored on the EEG machine. And so here is a diagrammatic depiction of individual leads across the skull cap for the EEG monitor. And you can see that they vary quite a bit. And so since we have such a long experience with EEG, we understand what a voltage should look like in general for a particular person's age. And these can be compared to age-adjusted averages to help people understand whether they're on par or behind or ahead of their peers at that age. And I think at this point, I'd like to hold up on the presentation and see if we have questions at this point.
Okay, let's see. Folks can post questions on the chat window. I can read them out. I had kind of a simple question, Pierre, just as you're about to go into more depth on the EEG, but how did you come to be aware of the WAVI device itself, and what's the relationship there?
Well, so there's a preventive cardiologist in Denver, and we actually use his tech to do the CINTs, and once a year we get together and we do a little preventive cardiology summit. And I met the WAVI people there. They were presenters. And then I talked to Dr. Boone about his use in using the WAVI scan. And it was like, oh, you know, it just clicked for me at that point, especially in that context. So he had started using the WAVI scan to buff out the testing that he does with patients. And curiously and interestingly, he does a lot of non-invasive cardiovascular assessments for the FL. So, which of course this has application in, which we'll talk about in a little while.
Yeah. Okay. Great. We've got a couple of questions on the line. Let's see. This is kind of maybe a quick one here. We can talk more later. But are there, since you have a kind of a broad practice, are you familiar with people using these, or do you use these devices for people who are meditating or when they're meditating?
So the answer is no, and not because I'm opposed to it, but mostly because I'm using this not as a research tool, but helping people understand where they are with the health and biology of their brain. I'm sure that there are EEG studies of meditators, and it would be interesting. I haven't reviewed this recently, but it would be interesting to see if the auditory provoked technology adds anything to it. And there's another thing that we will be talking about that relates to your question, which has to do with heart rate variability, which has everything to do with meditation, because heart rate variability, which is going to be one of the added features of the WAVI platform, is a measurement of the balance between activated and relaxed nervous system, or parasympathetic and sympathetic nervous system. And so the heart rate variability component is still in the beta testing, but we're going to talk a little bit about that. And so it will be interesting to pair heart rate variability and EEG, because I don't think we have a big database comparing these two kinds of measurements.
Mm-hmm. Okay, cool. Thanks, Amy, for that question. We may come back in future events. I'm hoping to have a speaker from Interaxon with the Muse device, and their whole business model revolves around meditation. So that'd be an interesting place to have that conversation.
Yeah.
One more question, Pierre, from Wayne. This will give you some kind of a hint of where some people like me are coming from. Are you able to read when you have the headset on when a person moves or moves hands, fingers? How much detail, granularity can you see?
Well, quite a bit, but in this platform, those things can swamp, okay, the auditory evoked potential, and so we have people hold quite still. Because we really want to get this precognizant brain processing speed and power measurement done, and we want to get a really clean measurement when we do that. And so movement tends to interfere with that. And so it's because of the focus on getting this deep precognizant processing time as a biological marker, we're trying not to get people to move, especially anything that is happening from the neck up. Those muscular electrical signals will swamp the finer signals of on the scalp coming up from the brain.
Mm-hmm. Great. So again, Wayne, thanks for the question. And a future topic here for me is going to be to get someone talking about the use of BCI for assistive technology, where movement's more is the point. And so please stay tuned for that. All right, Pierre, why don't you keep going?
All right, let's go to the next slide. So we were talking about power as measured as voltage on the surface of the brain. And one of the more interesting ways to show that graphically is shown in this slide. So where the red would be high voltage and yellow would be moderate and green would be low voltage, we can map the voltage across the brain. And typically on the scan, we see the highest voltages near the midline. And so, and then things tend to cool off as we move to the periphery. And so we see that again and again. So if we look at our standards at the bottom of this graphic, you can see that there's some light pink in the middle and then yellow and then green as we get to the outside. But these can, of course, be very individualized. So if there's a program to improve brain health and we repeat the WAVI scan, say in a month or two, and we see that the voltage has improved, you can tell that individual, right, that we're seeing more electrical activity and that we're seeing some improved health. Likewise, because the brain can be very idiosyncratic, sometimes we see very irregular or asymmetrical patterns of activity, but those still can be compared in what you might refer to as an N of 1, and we can tell if they've improved or not. And so moving from either typical or atypical or novel or commonplace kinds of scans, we can still follow people over time, depending on the interventions or recommendations that we made in order to monitor for, in this case, what we're measuring is voltage or power. Next slide. And then because the WAVI database in particular they did some clinical studies using athletes around concussion, it's a pretty good way for us to begin to understand insults to the brain, in this case trauma, and how the WAVI scan helps us to understand whether the biology of the brain is returned to normal or not. So this is an example of an 18-year-old athlete who had a concussion, and we can see here, fortunately she had, and this, because it was a study, she had a pre-participation scan, and we see that on the far left. And then we see her next scan has cooled off substantially, and the biology of the brain has been easily demonstrated to be ill-affected by the concussion. And then the concussion protocol that was applied by the athletic coaches cleared her for participation, and yet she didn't want to participate because she could tell her brain wasn't back to normal. So it brings up the issue about changing those protocols. But you can see that her brain function does come very close to her preseason baseline after taking herself out of participation for additional time past the cleared participation time. And so this may be a very individualized thing. We may not have set protocols that can always tell us when a brain is recovering. The brain is really the canary in the coal mine, and lots of things may slow or impede its recovery. Next. And the next one is a player in which the recovery wasn't found, right? So we have an excellent, very active, biologically active brain in the preseason baseline in this football player. And then we see how dramatically it cools off and the voltage drops globally around the concussion event. And he's cleared for participation, yet there's no evidence of voltage return to baseline, nor is there evidence that he returned to it at the end of the season. So so while this is around concussion, there are other kinds of insults that we worry about in clinical practice. And so there is a thing called pump head, which has to do with prolonged anesthesia for open heart surgery. And this is a cognitive decline that's seen after open heart surgery from prolonged heart-lung machine use during open heart surgery. But we see also patients who have what we call chemo brain, who've had chemotherapy for cancer reasons, and they've noticed an important decline in their brain function and cognitive ability. And then we have lots of other functional problems that people complain about. They go, I can tell I'm just not as sharp. I just know. And if they do comprehensive cognitive testing, they can see that they're in range, if you will. But the person still knows that their brain can do better because they're used to that baseline. And even though they fall into normal limits for cognitive testing, they can tell that they are experiencing an important cognitive change. Next slide. And so processing speed is another important biological measurement of brain processing and health. And here comes the auditory evoked potential. So these have been used for decades now. It was originally used as a way to screen people for a rare tumor called an acoustic neuroma. And you could use this auditory setup where you measured the evoked potential from the neurons in the auditory nerve to diagnose whether or not there was a tumor interfering with the hearing nerve. And so this goes back decades. And so there's a huge databases that monitor or document what we would expect at various ages, or if there is disease in the auditory nerve. So it's super reproducible. We have a large database. And of course, it's available non-invasively. And so this instrument is made by wearing the EEG cap and then having the headphones on. And so there is an ambient background chirp, okay? And the patient is instructed to click a mouse when they hear a novel sound, which would be either a beep of a higher or lower frequency. And then while we're measuring the EEG, we can see the precognizant brain determining whether or not that chirp is actually a novel sound or not. Next. And so it turns out that acoustic neuromas are rare, but P300s do correlate with healthy aging. We know that there's a certain decline, or I should say, a certain lengthening of the time it takes to auditory process as we age. So we know what that healthy or normal aging process looks like. And we can see changes in the processing time in the auditory system in a variety of other diseases: Alzheimer's, cardiac diseases, addiction and mood, and concussion. And there are others. And so we can see that it is a good index function of the brain to keep an eye on in terms of understanding the biology and health of the brain. Next. And so here's an example of what you might expect in terms of Alzheimer's disease. So here we see in this, on the left of this diagram, we see the electrodes and where we're taking the measurements. In this diagram, the nose is facing up and the ears are to the side. And we can see in the green graph the downward sloping voltage measurement at that lead site. And we can see it drop to its low point, which we call the P300, because it happens at around 300 milliseconds on average. And then it recovers upwardly. And if you look at the gray dotted line in either lead, you can see that in people with MCI is mild cognitive impairment is what that is short for. So this is not Alzheimer's disease, but these are people who have noted a decline in their ability to cognate and think. And we can see that the P300 is drifting to the right. In other words, taking longer for the auditory system to process that sound. And then if you look at more severe cognitive decline in Alzheimer's disease, we see it's pushed even further out. And so I just use this as an example of what we're looking for and what the information looks like when we're looking at the WAVI scan. And of course, other things can push the P300 out longer. And so, or in other words, other conditions can lengthen the processing time or slow it down. And again, this is all precognizant. This is before the patient is aware of the notion that this is a novel sound. It takes less than 1/3 of a second for the brain to check, yes, novel sound. And so that takes about 1/3 of a second. Next. And so, and I mentioned heart rate variability, but we're excited at Helios to be a beta site. We're not set up just yet to incorporate it on the platform, but we're excited to do this because, as I mentioned earlier, knowing about heart rate variability, and again, these are pretty giant databases that help us understand whether somebody's variability is healthy or not. And variability in biology is actually a fundamental notion of health. And so any system that we look at, either ecologically or subsystems within an organism, if we see a healthy range of variation, not too narrow and not excessive, then that tells us about the health of the organism or the system, right? So we want that, if you will, flexibility or adaptability. We want that variability to be there, but we don't want it to be too rangy, right? And so that's true for heart rate. We don't want it going too high, and we don't want it going too low, and we don't want it going rapidly between the two, but we do want it to be able to move adaptively and flexibly and not within too narrow a range. And so heart rate variability does really give us a sense of how has this nervous system been in terms of its adaptation to stress. And so heart rate variability is a nice add-on to the WAVI scan. Next. And then I just want to talk briefly about what do we do when things are not good. And so, and this has to do with the orientation of my practice. And this goes for not just the brain. So we start with the 5 holistic principles of the things that make everything better. In other words, these are the non-negotiables in terms of health. And we're going to start with restorative sleep, which of course, fortunately, we have broken into a whole new renaissance in terms of our understanding of the physiology of sleep and its importance and its relationship with the other systems in the body. And so thankfully, we're at a time where we're understanding much more about sleep than we used to. And the more that we understand about sleep, the more we understand about how important it is. And then there's the inner life. And I mean by inner life, I mean, what is that person's relationship with their divine? What is that person's relationship with their sense of being, their sense of welfare, and their mission here on the planet? And so an inner life has to do with the big questions on the inside. And then outer life has to do with the social support that they experience. Is it thin or is it thick? Is it appropriate? Is it supportive? Is it a positive or a negative? And so your ability to get and receive physical and emotional contact, not the least to mention love, is important in terms of the health of the individual. A proper diet, in other words, a diet that is specific to the constitution of the patient, and then exercise as well. And so these are non-negotiables. We don't expect people's health to improve if there are one or more of these things are seriously out of whack. And so they're always on the table. Next. And then comes the clinical practice. And so this can be, because the brain is the canary in the coal mine, there is no stone that we might not look under. So that includes genetic testing. It turns out that there is in particular ApoE genotype testing, which gives us a risk factor for the development of dementia or Alzheimer's disease. And having that gene does prompt us to look to look at the patient's brain function more closely and look at other issues. And then because we're keen on nutrition, we have quite excellent access to panels of intercellular nutrient panels, and of course hormones need to be in balance. The immune system needs to be not chasing windmills in terms of allergens. And then of course, I've been talking about cardiovascular health and how important that is for brain health. And then there are inflammatory processes that need to be identified in some people, toxin detection in some others, and infection identification in others. And I mentioned overnight oximetry as a non-invasive and inexpensive way to peer in to individual sleep patterns and to find, in particular, obstructive sleep apnea and other disturbances of sleep. So this turns out to be really important. About 90% of people with sleep apnea do not know they have it. And no amount of clever doctor questioning will help find that other 90%. So for 40 to 60 bucks, I can set somebody up to just screen them. And did I mention that the WAVI scan is inexpensive? I mean, relative to an EEG, let's just say. I mean, everybody's idea of inexpensive varies. But so we charge $80 to do the WAVI scan. It takes less than an hour. And a EEG that you would get in the hospital, they start at over $300. And they don't include the information that we're discussing today. So that's where I'd like to wrap it up and start more questions. And I'm going to take a sip of tea.
Great. Thanks, Pierre. Let me try to get out of here. And I don't see any new questions on the chat. If
I think there's a question from about hyperbaric oxygen.
oh, there it is. Yeah, now you can see that. Go ahead.
Yeah, it disappeared quickly. So what was the full question?
So this is from Trent. Thoughts on hyperbaric oxygen therapy for brain damage?
So this has become more interesting. I think there is. I don't have the specifics of what we call HBO or hyperbaric oxygen treatment and brain injury, but it has been embedded in other programs, comprehensive and holistic and integrated programs for recovery from traumatic brain injury. And my sense, and that, well, and there have been practitioners locally who have used HBO. So here's what I can tell you clinically. It's been a mixed bag. So I've had patients who've done anywhere from 30 to 40 1-hour sessions of hyperbaric oxygen. Some of them noticed improvement and some of them didn't. Now, what does that say? That does not mean in any way that it's of no use, but it probably is not a standalone treatment for brain injury. So what we know about Alzheimer's disease is that, and why there's not a single unified theory about it, right, is because you can have an unfortunate coalescence of other injuries to the brain, some that have been chronic and some that have been more recently added, right, that conspire to bring down the biology of the brain together. Individually, they probably would not be consequential, but collectively they are. And so the number of things, it has been proposed that there are no less than 36 of these things that might conspire to come together. And so clearly HBO is only addressing one of those, which has to do with oxygenation of the brain. So it might be that somebody, well, for instance, I would imagine and would be supportive of somebody, for instance, who had stroke, who we know has ischemic or low blood flow to the brain, them getting HBO, especially in the post-stroke, in the acute phase, because we would imagine that that would be rescue.
Good, thanks. We have another question, but let me ask quickly. You mentioned the cost of the WAVI.
Yeah.
If you do the WAVI version, is that reimbursable?
So, yes. I mean, I'm not interested in testing things I can't do anything about. I mean, the last thing I want to do is sit here and rub my hands and go, dang, that's too bad. I wish we could do something about that. So my previous answer actually gives you a sense of that. So there are lots of places, right? In my mind, there's a priority list of things. And so while I'm talking to patients, I'm keen to ask about sleep, for instance, because without restorative sleep, that's not a brain that's going to look good on the WAVI scan. And so I'm going to want to know, that's going to be a high priority place to intervene if there are known problems, and certainly a place to look if we're not sure. But there are a variety of other things that go into that list, and they include oxygen. It turns out blood sugar is really important. Your brain does not like being low in blood sugar, so looking for people with hypoglycemia is one of those things. And then the second tier has to do with a short list of hormones for which the brain is quite dependent as well. And then there's 32 other things after that.
Another question from Suhas. What are your thoughts on using neurofeedback? Kind of a broad
on
question,
neurofeedback,
but,
so I've had very positive responses to people who've done neurofeedback. And so, and I like the premise of neurofeedback where you're bypassing the cognizant brain. You're not letting it get too involved. And so this is, I think, for some people a really important thing because their head does get in the way often, and especially if they have PTSD and other kinds of anxiety disorders, it could be that simply talking about some things is provocative and disruptive and reinforces a pattern that they're trying to get out of. Whereas if you are simply looking at a screen and your brain, right, is feeding back information of images that it likes and finds calming, and then the software keeps producing more and more similar ones, then you're actually retraining. You're creating, if you will, bigger neurogrooves to help produce more variability. And so the idea, the premise, I believe, is to create a sufficient habit of getting into, for instance, a relaxed state. And therefore, having that habit more accessible when you're not on a neurofeedback platform.
Hello, can I ask a follow-on question?
Sure.
Sure.
Yes, so my background is actually in neuroscience. I used to work for a company that was doing EEG brain assessments for elite performers. I looked briefly at neurofeedback for ADD, ADHD. The literature was quite mixed.
Yes. So
it seems to be, where do you think neurofeedback is great? Meditation and just
well, let's start with what is ADD.
Yeah.
So ADD is a dumping ground for people who have poor attention. It's a mix of problems. It's not ADD is not a biological,
sure,
well-defined thing. It's
okay.
a cluster of people who struggle with their attention. It's like headaches, there could be lots of sources for headaches. And similarly, it's been proposed that there are at least 7 types of ADD.
Mm-hmm. So
you would imagine in some of those types, it's going to work well, and others it's going to be very poor.
Hmm.
So that's a messy place to study something like neurofeedback. I mean, if you're trying to create evidence, right? And
sure.
you'd want to start with something that has a clear definition, biological, right?
Could you perhaps suggest some? Oh, if there's time.
Oh,
very quickly.
In terms of studying neurofeedback and other conditions, I would think PTSD would be right, an ideal place to do that. One is because there's a lot of it, and two, we understand a bit about the process and the treatments for it, and we need non-pharmacological therapy for it desperately.
Thank you. Thank you.
Okay,
Yeah.
thanks. Great questions. Thanks, Pierre. So I hope everybody got as much out of this as I did. I wish we had more time, and maybe Pierre will have you back. But thank you very much for the presentation. Just want to get quickly up, if you can see my screen, a couple of coming events. If you registered for this call, then you'll get an email from me about the next couple of events, one on June 4th. The next two are a little bit of a twist, not so much about the medicine or the technology, but about the business models for the technology. And so we have a couple of startups. One is Okaya with their CEO, Gregory Minville. And then following up very quickly after that, a company called Immersion with Scott Brown, using neuroscience for predictive behavioral activity and in a range of fields. And so that'll be pretty interesting as well. If you're new to the organization and you want more information, please get in touch with me at that first email, boulder@ttacademy.co. And I'd love to have your help in doing more of these kinds of events and more collaborative work when we can all meet in person.
Yes.
Thanks. Thanks,
Thank
everybody.
you.
Have a good rest of your day.
Thank you.
Thank you, Pierre. Thank you, Don. Appreciate your time.
You're welcome. My pleasure.